CYC is a free channel, presents the Word of God for everyone. Your support will help us to continue the mission. Visit our website, cycnow.com. Even $1 will make a difference.
Hello, and welcome back to another episode from our series on CYC MD Part 2. Previously, if you recall, we met with different healthcare professionals and providers, all of whom gave us an insight into their schooling, education, as well as into their careers. In this new series, we are indulging and digging deeper with our doctors into their focused areas of practice. Today, we will be touching over the topic of breast cancer. Breast cancer is the most common cancer affecting women. And just to give you an idea of some statistics, I have here the American Cancer Society estimates that for breast cancer in the United States for 2014, about 232,000 cases of new invasive breast cancer will be diagnosed in women, and about 62,000 new cases of carcinoma in situ, which means it's the earliest form of breast cancer, will be diagnosed. And of all those, about 40,000 women will die of breast cancer. And these are just some statistics. We will be talking more in detail of just treatments and diagnoses of breast cancer. With me today, I'd like to welcome Dr. Hani Ashamola. Welcome, doctor. Pleasure to have you. Who is a chairman of radiation oncology at New York Methodist Hospital, and also a clinical professor at Cornell University. Welcome. Pleasure to have you again.
Thank you, Mary.
It's been a while, but we met again.
It's nice to be here.
So I did note of some statistics, and actually it's funny because I was on the phone on hold actually with in a doctor's office. I was calling a doctor's office, and they tend to just, when you're put on hold, they give you even just some advertisement of more statistics. And being that I was going to tape with you, I actually my ear was actually in tune with another statistic that they noted, and I wrote it down because I wanted to check with you. And it said that a woman living in the United States, on average, 1 in every 8 women have a lifetime risk of being diagnosed with breast cancer. And they say that statistics actually for breast cancer in general has increased in the past decades. And why do you think so?
There are some claims that there may be reasons amongst environmental, radiation exposure, but we really don't know. But the only one thing we are very sure of, that the diagnosis is made easier and sooner than before. So in the past, when we used to diagnose late breast cancer, now we are diagnosing early and more breast cancers because we have the ability to use many other modalities to find out who has breast cancer. So it could have been the same number, but we are diagnosing more because we have better ways to do that.
So with technology?
Yes.
So you mentioned environmental changes also. What are some reasons or risk factors that cause breast cancer?
So the only one that's proven is hereditary. Not every mother with breast cancer will give breast cancer to her daughter, but some oncogenes, some genes, some chromosomes, especially something called BRCA or BRCA1 and 2, which has a lot of inheritance in ovarian cancer and breast cancer. However, this is not common among Egyptians' descent, more common among Ashkenazi Jews. So this is the most common, more profound, well-established reason. There are so many claims in the internet and books about types of food, some occupational exposures, certain types of radiation if you fly a lot, but none of these things are proven right. So I wouldn't bother any woman with any of these factors, what to eat or not to eat, because they are not well proven. However, if her mother had breast cancer, we usually start examining her earlier and getting some x-rays earlier than 40. So if 40 is the real age for mammograms and her mom or grandmom had breast cancer, then this young lady will start at the age of 35 or 37 to get her first mammogram.
Mm-hmm. So in this case, you would recommend a genetic counseling?
Okay, so genetic counseling is only recommended if a person wants it, and if it's an invasive breast cancer, not the ductal carcinoma in situ that you mentioned initially in your introduction. And also if there are some family members, even if they are distant, with prostate cancer in men or breast cancer in women. If we find, then we ask this lady if she's interested to have genetic counseling. And the genetic counseling sometimes is not important to the breast cancer patient as much as more important to her descendants, her young daughter who is 5 years old. Some people use the BRCA to decide for future ovarian screening because some of these chromosomes can also harbor future ovarian cancer, not just breast cancer. So yes and no, and it needs to be placed with wisdom which one should go for genetic counseling.
Okay. So how is breast cancer detected? Can a woman feel breast cancer?
So we always ask women to examine their breasts, usually after the age of 35, 40, usually mid-cycle, because it's very painful around the cycle. And most of the times, breast cancer today are not discovered by palpation, by finding it. Because usually if you feel it, it's over 1 centimeter already. But there are many other ways, not just by the lady examining herself. If she goes to her gynecologist or her primary doctor and he examines her, so self-exam, doctor exam, and then mammograms and sonograms of the breast, and we usually don't recommend that before the age of 40. So unless there is breast cancer heritage in the family, then at that time we recommend it earlier. But if not, then we only depend on just waiting until the age of 40, and then we start self-exam, breast exam by the doctor, mammograms and sonogram, and we do not act upon any of these unless there is an abnormality.
Okay. Well, I know sometimes they also teach women about self-tests, and they tell women to get familiar with the way that their breasts feel. So should any lump be alarming, or should anything, or is having lumps a normal thing, or should we right away go ahead and see a doctor?
A lady should familiarize herself with her breast exam. It's normal for young women, and a lot of Egyptian women I find, they have much more what we call dense breast, cystic breast, and for the touch it feels as if she has lumps, and at the end they are just multiple cysts. And cysts could be full of fluid or full of some proteinaceous fluid, and they are not cancer. However, because she will never know the difference between a benign versus non-benign tumors or palpable lesions, we like her, if she feels something, to go to her doctor and be examined. But you are right, not every palpable lesion in the breast is a tumor, and not every tumor is cancer. So there are lesions which are completely not even tumors, they are just changes in the breast. And there are tumors, but benign, and they are very common, by the way, and probably the most common tumor in the whole body is the benign tumors of the breast. And then there is malignant or cancer.
So, but I do think it's still comforting for people to know that upon doing a cell
Right.
breast exam, should they feel something, it's not always a red flag.
Oh, actually, most of the times these are benign, what we call fibroadenomas, which, as I said, very common finding in a young woman.
So you mentioned, so we can get this out very clear. So screening should begin at the age of 40. And you did mention getting a mammogram. How do you diagnose for breast cancer?
So, as I mentioned before, examination, if there is a palpable lesion, you do a mammogram and sonogram. If they confirm, or even sometimes if they don't confirm and we feel something, we get a biopsy. And a biopsy doesn't have to be a surgical procedure. We don't open. It's usually done in outpatient basis. It's a simple needle placed under usually a little anesthesia on the skin, so she feels nothing. We take a piece of that lesion, I don't want to call it tumor, and we examine it. In 3 to 5 days, we get the exam. If it's benign, we tell her it's benign. We are going to watch it, and every 6 months or a year, we get a mammogram. If it's malignant, then we need to take it out. So the diagnosis is usually done by taking a piece of the tumor.
So touching on the topic of biopsy, actually, people say that if you do a biopsy, the cancer will spread.
Yeah.
What is the truth behind it?
So this is a very common myth.
I was going to say,
And
after myth.
yeah, and I am hearing it somehow from the Russians and Middle Eastern. Those are the two cultures that somehow so drastically far from each other, but they sort of agree on this, that, if I have a cancer in my stomach and they open, it will spread. To tell you the truth, there is no scientific merit to this at all. There is no science to explain that this came from any reasoning. I am not sure where it came from, but I want to assure my ladies listening to me that, or the men who have maybe other reasons to have a biopsy, not because you do surgery or a biopsy, the tumor will spread. That has no basis for truth.
Okay. So before we touch into treatment, we know that there's early forms of breast cancer, and as far as most cancers go, they are divided into stages.
Right.
Can you touch over just stage and grade of breast cancer?
Sure.
Those terms when you do hear it from
Yeah.
pathologists.
So this is a very good question. Actually, one of the very common cancers we see today, because all women are going for mammograms all the time, is what you call carcinoma in situ. It's written in the internet under the term DCIS, which stands for ductal, which is inside the ducts, carcinoma in situ. In situ is a Latin word for that the cancer is in its place. And that's what we call stage 0 breast cancer, because the cancer on the complete surface. And as long as it's on the surface, did not go invade the tissues, we don't remove the breast, we don't even remove the lymph nodes under her arm, she will never get chemotherapy. This is 100% curable and needs all what it needs, simple treatment, which I guess we will come to. Then invasive breast cancer, which means it went from the basal layer, from the superficial layer into the deeper tissues. The problem with that on the deeper tissues are all the blood vessels and the lymph vessels. So we worry about spread. So these are the cancers from stage 1 to 4. And 1 to 4 depends on the size of the tumor. So if it's small size, less than 2 centimeters, stage T1, then 2 to 5, T2, and then above is T3. Once it starts coming through the skin or becomes so fixed and hard, or the arm gets swollen, this is very advanced. We call it stage T4. And I am preaching here to many of our ladies who come from Egypt, and they are very embarrassed to go to a doctor, and they feel a lump, they don't want to see anyone, and they may dismiss it because it's they call it milk incarceration, like there is some globules of milk that got there, and they forget about it. All what happened later, unfortunately, it grew, and it can go through the skin, and unfortunately, we see many of our Egyptian ladies, because of embarrassment, they come to us a bit late, or sometimes very late. So stage 1, very small. Stage T4, when it go through the skin or becomes so solid, or very ugly type of tumor. Of course, there is a T for tumor, N for nodes, and it depends how many nodes under the arm. So we examine this very carefully. We get X-rays of this area, and we ask the surgeon to give us a sample of the lymph nodes, because we need to know if the lymph nodes is 0, meaning N0, that's a very early stage, most of the times curable. While if the nodes are positive, if it's 1 or 2 nodes, still very curable, but we don't want to see a very high number of nodes. That becomes a higher stage. Still treatable, a lot of times curable, but of course needs much more treatment, as we will discuss. The final word, final letter is M. So all the stages in any cancer, T for tumor, N for nodes, M for metastasis, which means that the cancer left the breast, left the arm, and went to the lung, to the bone, to the liver. And that's what we call spread of cancer, or we call it M1. So early stage, small tumor, no nodes, no metastasis. The worst stage, metastatic disease.
And that's why we actually, because once you probably get to that metastasis stage, the chances of survival, of course, is probably...
In breast cancer, amazingly, a lot of ladies are living long with metastatic disease, but we cannot claim cure. Once you have an M1, we control the cancer, we make them live long, but we may never cure them. But with all the new technologies, they are living much longer than in the past, even with metastatic disease. Of course, there are many variables. I may not be able to discuss them, but generally speaking.
Thank you very much. We're going to stop for a short break, and we'll be right back with more on treatment and other advices and recommendations. Stay tuned. Welcome back. We are back with Dr. Hani Ashamallah, who's the chairman of Radiation Oncology at New York Methodist Hospital, as well as clinical professor at Cornell University. And we are continuing our discussion on breast cancer. And as we said, breast cancer is the most common cancer affecting women. And we hope this knowledge that we are talking about can help you in relating this information to either your mom, your mothers, grandmothers, loved ones, or even friends. So continuing back.
Sure.
Now, we want to touch over treatment. I know many times people come to you and their first question is this treatable? How long is the treatment? What am I supposed to worry about? Side effects and all that. Yeah. So as far as treatment goes, I know everyone knows of chemotherapy right away. So what is your take when someone comes to you as far as treatment goes? So
actually the first plan of action, once the biopsy is proven and we know the cancer is confined to the breast, maybe the lymph nodes, the first plan of action that the surgeon see the patient. Mm-hmm. And I know women think right away that I'm going to lose my breast. And this may not be understood by her husband, that he says, yeah, so what? But it's very, very psychologically hurtful for a woman. This is very important part of her body. But I want to also put at peace all my ladies listening, because most of the breast cancers diagnosed today do not need removal of the breast or what we call mastectomy. Actually, 75%, maybe more, of the cancers diagnosed today usually are the smaller type, not invading the skin, as I said earlier. And what we do is we remove the tumor plus some breast tissues around it, and we call it lumpectomy. It came from the word lump, removal, so called lumpectomy. We also ask the surgeon to remove a couple of lymph nodes from under her arm to know if it's N1 or N0. Once the surgery is completed, an oncologist sees the patient, somebody like myself or a medical oncologist and a radiation oncologist. The three doctors need to talk to each other: a surgeon, a radiation doctor, and a medical oncologist. If the cancer is very early and the lymph nodes are negative, most of the times we do not give chemotherapy. We give radiation therapy to the breast because we worry that the cancer may come back. The radiation therapy is very simple. It's almost like taking a picture of her breast 5 minutes a day, 5 days a week for about 6 weeks. She feels nothing. She never gets her hair lost, no vomiting, no nausea, no diarrhea. She can perform normally. She can go to meet her children, grandchildren. She go to church. She can go everywhere.
And this, we said, is the early stages.
So early stages. Yes. Usually nodes negative, smaller tumor, 3 cm or so. And usually the only side effect that she feels that her breast is a little red, almost as if she's exposed to the sun. So she goes to almost the phases of sun exposure, a little redness, then a little bit of darkness of color, of course, of her breast, and then go back to normal. Usually cosmetically is 100% excellent. As long as she didn't have any mutilating surgery, she would be very pleased with the cosmetic results, and psychologically it's excellent. Usually these stages early, but sometimes we put them on one hormonal pill if her cancer is receptor positive. Now, you asked a very intelligent question, which what if it's a little bit advanced? Lymph nodes positive, a slightly larger tumors. So once we finish the surgery, we take the tumor out, she has to get chemotherapy. There are many lines of chemo. Usually it's given every 2 weeks or every 3 weeks, and it's given through the vein. Sometimes the doctor has to put a small port right here for them to inject the chemotherapy through, so she doesn't have to have her hand poked every time. The chemotherapy has much more side effects than the radiation, but in today's age, with all the medications available, ladies are functioning normal. Unfortunately, they may lose their hair, they may have mild nausea. Usually the vomiting is easily controlled. So the chemotherapy takes about 3 to 4 months, not every day, but every 3 weeks, so about 4 up to 6 cycles of chemo. After she's done with the chemo, she goes for radiation. So if she has advanced cancer, then she goes for surgery first, chemotherapy next, and then radiation last. If she needs a hormone pill like tamoxifen, Remedix, anastrozole, whatever the name is, she may get it later on. Really, the cure rate in breast cancer has becoming very high in the 80s, 75, 80%, 10-year survival. Of course, metastatic disease or very advanced stages, whether the patient neglected herself, was embarrassed to go to a doctor, or it happened that we discovered late, unfortunately, we will not cure them, but a lot of times we are able to control it for many years.
Now, how does having reached or not having reached menopause affect treatment?
Good point. So,
and menopause being, I guess, once the woman, we would say, loses her period cycle stops.
It's a little bit more than just losing her period. I mean, menopause, loss of period, but more importantly, loss of most of her ovarian function. And that's what gives the lady the hot flashes, the feeling of depression sometimes, which goes from the age of, say, 49, 52 to, say, 55. Mm-hmm. And hopefully it takes a year to two. Unfortunately, some women take longer. Now, breast cancer in premenopausal, meaning younger ladies, less than 40, sometimes is a little bit aggressive than women, their moms and their grandmoms, meaning a lady who comes to me at the age of 70 versus a lady who comes to me at the age of 35. The 35, sometimes her cancer may need more chemotherapy because she may come with a lymph node than her grandmother who is 75, who most of the times the tumor will not have to need chemotherapy. What I'm saying is very generalizing. It may not be true. A lot of young women, we treat them completely with radiation, especially if they have early stage DCIS, as I said, which is stage 0, and no chemotherapy at all. And sometimes not even hormonal therapy. So, very good point about that the menopause sometimes makes the cancer less aggressive.
So, touching on also the premenopausal area, many women in that premenopausal stage or age group, should they do receive that chemotherapy, worry about not having kids again, or worry that now that they received this chemo, their chances of being pregnant is very slim. Mm-hmm. So what are options to preserve this fertility?
So that's a very good question as well. Unfortunately, the chemotherapy can cause some significant ovarian injury. In about 1/3 of times, the ovaries regain the functions. Maybe 30 to 40% of the times, the ovaries may regain function, and ladies can become fertile again. Mm-hmm. However, we do not leave that to chance. If I have a 30-year-old woman who was married 2 years ago and now she has breast cancer and she needs chemotherapy, not radiation. Radiation does not affect her ovarian dysfunction. So if she gets radiation only because she has an early stage, 6 months later she could be pregnant. We don't want her to be pregnant during the radiation because we worry about defective baby. But once 6 months pass from radiation, she can be free to stop contraception. Now, in case of needing chemotherapy, as you mentioned, we have today a technology called ovarian freezing. Basically, they extract the ova in the mid-cycle before the chemo starts. So laparoscopically, they open a small opening by the belly button and a scope goes in and sort of catches the eggs, the ova, and freeze them in a certain bank. They call it the ovary bank or the eggs bank or the ovarian bank, whatever. And they keep them until she is ready to have a baby. She's done with the chemo, her ovaries didn't work, and they take her ova and they sort of implant it in her uterus with the sperm, and she may be able to conceive. Now, this is actually can be expensive, but at least in New York, there are some centers which they do it free for young ladies who are in need of chemotherapy. The other type is to almost take in part of the ovary and freeze it and then reimplant it back. This is a technology is being developed. Some places are more developed than others, but at least the ovarian freezing is much more commonly used.
To just touch over very briefly actually on, would you say there's any nutritional or dietary supplements that can help? I know sometimes people feel that they're taking either radiation or chemotherapy and they want to feel that they're taking a vitamin, dietary supplement, anything nutritional to help them. Is there anything you can recommend, or is there...
So we usually ask our ladies to just eat well. Mm-hmm. They are not prevented from a certain food. and there isn't a food that makes their immunity better. This is all myth again. We usually don't like vitamins during the radiation. We ask them to avoid vitamins because there are some supplements with the multivitamins that sometimes can make the skin react worse to radiation. However, the food is really not a major problem either way.
Just to wrap up, I know you deal with patients on a day-to-day basis that come to you and they ask you for advice, just whether it's psychological advice, and people just want someone to make them feel that they will be well.
Sure.
So what advice would you recommend, or do you give your patients?
Oh, all the time. In cancer in general, and breast cancer specifically, they need a lot of support. And I love to see their family with them. I love to see their husbands or son or daughter or mother to come with them, because the family support is very important. The physician support is super important. Now we are speaking as Christians, so if I find a Christian woman, regardless of her denomination, I always bring God in the picture. I tell them how much they need to have faith, and they need to go to their church and to have a support system within the church. If they believe in communion, then I really, regarding Catholic or Orthodox, I try to make sure that they take communion, even if they are not Egyptian. If they are not Christians, I still try to make them have a faith system in their own belief system, but at least their family support need to be there. It's really a more comprehensive approach. And if I find any lady really going through depression, I need to talk to her a lot, and sometimes we need to give them some medications to alleviate their depression. But in today's age, when the side effects are less than before, prognosis is much better than before, there is a lot of hope that we give them. So, and there is always second and third line should the cancer comes back. So thankfully, the story always have not just one end. There is always something we could do, and that usually makes them happier.
Thank you, Dr. Hani. Pleasure to have you.
My pleasure. Thank you.
We hope you enjoyed our episode today on CYC MD on this topic of breast cancer. Women, as we mentioned several times, we do and highly recommend and encourage women at the age of 40 to start going for their breast exams, for mammograms, and any screenings. Because as Dr. Hani mentioned, the earlier you catch the cancer, the easier and the higher the survival will be. And lastly, as always, keep and put your faith in God. Until next time, God bless.